A very good morning and welcome to the Public Health Thought Leadership Dialogue presented by the Swee Hock School of Public Health. Today's topic for discussion is cannabis policy, the example of Canada. And we're very delighted to have with us today guest speaker Prof. Rehm, as well as our esteemed panel of public health experts. I would now like to invite Dean of Swee Hock School of Public Health, Prof. Ying, to say a few words and introduce our distinguished speaker for today's session. Prof. Teo, please.
Right, good morning, everyone. So, welcome to the National University of Singapore and welcome to the Swee Hock School of Public Health. I thought it's useful to give a very quick introduction about the school. It is about 8 years old right now, but we started off as a department in 1948 as the academic institution looking after public health in Singapore. So over the years, we have actually progressed quite a bit. We became a school in 2011. Now, one of our distinguished platform for discussing public health issues is the Public Health Thought Leadership Dialogue, where we specifically choose topics that we feel are very important and timely to have a dialogue with international experts. So we have had conducted previous topics included antimicrobial resistance, what is Singapore's stance against e-cigarettes, vaping, and also workplace health promotion. So you could see some of these issues are indeed very timely and important. Now for this year, this specific session, we have chosen the topic of medical marijuana. And I believe most of you would know some of the developments in Asia Pacific around the use or the legalization of medical marijuana. Our very good friend and neighbor, Thailand, has now legalized medical marijuana, and in fact, the law actually allows households to plant marijuana plants in their home, up to a maximum of a certain number of plants. And for Singaporeans amongst us, you will recall that just a couple of months ago, there was this news that some of our residents have been apprehended or prosecuted for actually growing marijuana plants in their housing block estate. So and the latest news just perhaps a week ago from Australia was that Canberra has now fully legalized the use of marijuana for personal use, and that means that it is not just for medical marijuana but also for recreational use as well. And it's even to the extent that each household is allowed to plant 4 plants. So you could see that there is this global shift in terms of the attitude and perception towards marijuana, be it medical or recreational. Of course, the rules in Canberra still need to be ratified by the federal government and by the health minister, but you could sense the direction shift. So today, it is my great pleasure to actually introduce Professor Jürgen Rehm as our key speaker for this Public Health Thought Leadership Dialogue. Now, Dr. Rehm currently is the Executive Director for the Institute of Mental Health Policy Research, as well as Senior Scientist at the Campbell Family Mental Health Research Institute at the Centre for Addiction and Mental Health in Toronto, Canada. More importantly, he's also a professor at the School of Public Health at the Dalla, Lana School of Public Health in Canada at the University of Toronto, and he heads the Epidemiological Research Unit at the Clinical Psychology and Psychotherapy at the Dresden University of Technology in Germany. He's a leader in generating and analyzing scientific data needed to inform policymakers around strategies to reduce alcohol, tobacco, and other drug-related harm. And this includes economic studies on the cost of substance use and the cost-benefit and cost-effectiveness of various intervention strategies. His current work is focused on estimating avoidable burden and cost of alcohol and drug use in Canada. Dr. Rehm is also a member of the WHO Expert Committee on Substance Abuse and the Scientific Committee of the European Monitoring Centre for Drugs and Drug Addiction. And I believe Dr. Rehm is also a friend of the Thai government, advising them on some of the policies around medical marijuana. So without further ado, I would like to invite Professor Rehm to the stage to give his presentation. Professor Rehm, please.
Thanks a lot. Thanks a lot for coming. And I'm not responsible for those new Thai laws. Advising doesn't mean that people you advise follow your advice. Try with your kids. Basically, these are the institutions where I'm affiliated with, and I will copy the following topics. I would like to go a little bit of a background on how the world is changing. The main topic is, of course, the experiences for Canada. I give another example from Thailand and come to the conclusion. Overall, I'll try to be within 30 minutes in order to have a discussion later where we can go into topics which are most interesting to the audience and to other people who have been concerned with marijuana, medical marijuana in Singapore. So what is the global picture? The global picture is whatever slide you show, you wait 2 days, it's different. It is very simple. Right now, in the last month, Luxembourg, which is not a big country, but it has legalized marijuana. Theo has already spoken about the Australian developments. So this is just a random picture, and there will be more and more green and blue there. And when we speak about marijuana, there are different ways we have to basically distinguish. First is the marijuana use. When we speak about marijuana, and the official nomenclature is, this is about plant and resin. If you speak about cannabis, it's everything. It's plant, resin, tinctures, whatever it is, any cannabis-derived product. But marijuana uses plant, cannabis plant and resin, and there are countries who have it legalized for recreational, countries for medical use, and countries who have them legalized for both. Then we have marijuana use legalized for medical use. Then we have the situation that marijuana use is illegal but tolerated. A lot of countries, more than 20 now, have this kind of a state. And then it's only tolerated for some marijuana products. And then we have the majority of countries is still having non-legal marijuana, but more than 80 of them have some kind of cannabis products which are legal for certain indications. And cannabis products are usually products which contain either THC or CBD, but in those countries, the cannabis plant and resin itself is not legal. So in the discussion, a lot of those terms are unfortunately mixed. So I will speak only about marijuana use, cannabis plant and resin. And if I speak about the wider cannabis use, I will let you know, and I will use the term cannabis. It's a gold rush. Basically, again, there are estimates up to 200 billions within the next 10 years. I just checked it on one random day in my hotel. The idea is not to convince you it should be 150 or 180 or whatever, or 200 billions. Those billions vary by newspaper, by different forecasting methods, etc. But they're always triple digits, and they're always pretty soon. So we're talking about an economically important development. And it is a huge global market, there's no doubt about that. And a lot of countries are trying to get a share. And frankly, it is already planned in a lot of budgets, and a lot of the governments will actually be completely surprised and disappointed by the outcome of that, because it is very likely that it will continue to be a very globalized industry where only a few companies in select countries will actually make the big profit, and all of the rest of the countries will have not a lot of profits. And I will give you the example of Thailand, of the health minister there, and the developments. So, what are the experiences for Canada? The basic gist is that we legalized cannabis in 2001. It was a Supreme Court decision. So it was basically one patient sued Canada for the right to use medical marijuana for his ailment. And as a result, the Supreme Court told government, you have to do something. What they did is they introduced a medical marijuana program after 1-2 years of deliberation, which was very bureaucratic, convoluted, and lengthy. And as a result, Canada has 35 million inhabitants. There were less than 200 medical marijuana users allowed in Canada 2007. So the situation was, in the beginning, medical marijuana got introduced into legislation by the court based on human rights considerations, and it was a patient. And then the government reacted, came up with quite a lengthy bureaucratic status, how to prove that you need marijuana as an individual. And as a consequence, we had medical marijuana legalized, but almost nobody used it. What happened, however, is that government tolerated a number of community-based medical marijuana dispensaries around the country, which basically means they were illegal, but police did not interfere. And police started to interfere if there were too many, if they were close to schools, things like that. But these were all informal rules. There was no legal use. How did those medical marijuana uses look like? And you see these are relative risks. And you see that basically the relative risk, from the change of the slides from the small to the big, the relative risk of 1 got moved, so it is now at 2.5. This bar should, of course, be at 1, so here. And you see that those people who used medical marijuana were quite affected. And they were affected that they had about 8-fold risks for poor and fair and poor physical health. In women, they had almost 10-fold risk for severe mental distress. So we're talking about very, very affected people who were in this old medical marijuana program. And if you look in the functional programs, the days people were missing in work or in their household, out of 1 month, 30 days, you see that basically, again, you had up to half of the month or even more in the case of the medical marijuana people, women, and unhealthy days in the last 30 days. Meaning, again, very severely affected people, people who on average missed, if there were women, 20 out of 30 days. That's a lot, if you do that on average. And so basically, that means the situation was a few very sick people used medical marijuana for a long time. The laws never got loosened for the first 14 years, but then there was enough pressure, and the pressure came, as in many countries, from two sources. A, there was NGOs, usually patients' associations, and they created stories about often kids. Little Theo cannot get his medication because the state is preventing him. Now he has epileptic seizures every 20 days. With marijuana, he would have epileptic seizures only once every half year, and this prevents him from regular schooling, etc. So you have human interest stories, individual stories, which create an impression that medical marijuana is absolutely necessary for a lot of people. Second is legal pressures. Legal pressures would be in a country like Canada that you sue the state saying that the state has prevented you from having the best medical care, which is not in line with the Canadian Constitution. So it's a human rights issue. And basically, so this law changed, and already the few hundred went to about 40,000 in 2014. There are more than 60,000 now, but now is no longer that clear because it's in the wake of legalization, they stopped counting correctly. So I would guess it is more than 200,000-300,000. And this was the law. What was the basic? It was a basic law which tried to widen it. And what were the reasons for that? Basically, it was one of the major themes about the Canadian federal election. So you must imagine a situation where basically you had a federal election in a country of 34 million, and it was one of the top 4 election campaign discussions. It was a discussion between the future prime minister and the old prime minister. It was unbelievable. It was hyped up. It was a real issue, and the 3 major parties had completely different stands. The Conservatives basically said, we are against legalization of marijuana. What they did, because 60-70% of the population was supporting it, it was about 60% before the election, 58 or so. What they did is they feared they lose the election because of that, so they allowed it through the back door, medical marijuana. So they didn't want to legalize leisure, recreational marijuana, but they basically opened it up for medical marijuana in a way which was open for everybody. So there are a lot of dispensaries. You went into the dispensary, you had to have a prescription of your doctor. So we did a study. We sent in stooges, for 50 stooges to those shops. They came in. Some of them were under the legal age for alcohol, which is 19 in our province. And they said, oh, I need marijuana. And they said, well, where's your prescription? They said, I have no prescription. Oh, go to the back. So they went to the back. They were phoning a doctor. The doctor says, what kind of ailment do you have? Oh, I have back pain. Okay. And the fax came, and they got a prescription, and they could buy marijuana, no matter how old. And out of 50 got marijuana. Of course, they were not allowed to buy. That was against ethics in our university. But they went to the point where they would have gotten the marijuana, and they had proof that they would have gotten it. The liberals were for legalization because they claimed that with legalization you can better public health control it, and the NDP were for decriminalization. So it was a clear cut. the federal election came, and this is just a random day before, and you see all the newspapers were full of marijuana. Now, legislation for legal cannabis. What was the idea here? Basically, she will help me do this.
Canada has one of the highest rates of cannabis use in the world. More than 10% of Canadians have used cannabis in the past year. Cannabis is not a benign substance. Frequent and heavy use can lead to significant health problems, especially for adolescents whose brains are still developing. Criminalization only intensifies the harms associated with its use. The criminalization of cannabis is not deterring people from using it. In fact, our current system is failing to prevent harm. What legal and regulatory approach can best reduce the harms associated with cannabis? A growing body of evidence shows that a public health approach can help tackle both the health and social harms associated with its use. The Center for Addiction and Mental Health is recommending legalization with strict regulation to help reduce the harms associated with cannabis. CAMH is offering 10 basic principles to guide regulation of legal cannabis use. These include a government monopoly on sales, establishing a minimum age for cannabis purchase and consumption, limits on availability, a pricing policy to curb demand for cannabis, curtailing higher-risk products and formulations, prohibiting marketing, advertising, and sponsorship, clearly displaying product information, addressing and preventing cannabis-impaired driving, enhancing access to treatment options, and an investment in education and prevention. The evidence is clear. It's time to reconsider our approach to cannabis control.
To do all this legalization, it took the government, they promised within 1 year, it took them 3 years. For example, 2 scientists of our center were borrowed to the government for 2 years just to hammer out some of those laws. It is not trivial to get this done. What about medical marijuana? Basically, it was used as legalization through the back door, and we need a different law. We have now a law where people are coming, getting medical marijuana for any kind of prescription, commercialized for a lot of different diagnoses where actually marijuana has been shown to worsen the condition. That means our major, number one prescription for medical marijuana is depression. Give me one study where marijuana is actually doing something good for depression. I can cite you, however, more than 30 studies where it in some way, shape, or form has worsened depressions. It makes no sense. And then people are suing the state if the state insurance, we don't have insurance companies, well, we do have insurance companies, but everybody is insured by the state first, and the insurance companies are only for additional insurance, like teeth, where if you want to have certain things, or like different operations which are not covered by the state insurance. And they're suing now the state insurance to pay them for marijuana, medical marijuana, to treat depression when it knows it worsens depression. And this is a very tough ruling for the courts, of course, but you see what happens if you open up a medical marijuana law with regulations which make no sense. So, what are the key questions? If you want to do medical marijuana, what do you do? Basically, you have to regard only conditions for which there is evidence. This means, in other words, if you do a medical marijuana law, do it as any other medication. If people would come out and say, I need this medication or that medication without any evidence, and you don't get a media story, oh, poor cannot get medication, then you would not give this person a medication, but you would say, look, for this condition we have only this and this and this approved medication. And you cannot approve a medication if there is no evidence, if there is contrary evidence. So any medical marijuana laws in any country should go back to the state that if it's a medication, treat it like a medication and not a public health issue. And there's also a number of questions which are highly relevant. One is, of course, driving. And if you look into the deaths which were linked to marijuana, you see for cannabis the following. And this is no longer medical marijuana. These are all kinds of cannabis. We did a burden of disease study for Canada and cannabis, and we came up with the following deaths. Overall, there are deaths from lung cancer. Very simple. Most of marijuana in Canada is smoked. Smoked often with cigarettes, and overall by people who die of cancer because whatever you do, you can put 100% ecological certified carrot grass. If you roll it into paper and if you put heat to it and you inhale it, sorry, you have a risk of cancer. And that can be any medication. You can put some medications on that. Doesn't matter. If you do these kinds of rolling and smoking like that, heated, then you have a higher risk for cancer. Second biggest is, of course, traffic. Right now, in inner city Toronto is about 11 million people, big city. Inner city Toronto, you have a situation where in the inner city district, you have more people dying of traffic crashes due to drugs than to alcohol. And that's, so if you do medical marijuana, if you do leisure marijuana, you should not drive, period. And if you have to use it daily, then you should have to give up your driver's license. Very simple. Because THC interferes with your ability, your cognition, etc. And let me give you another example which shows you a little bit about the ideas there. Thailand. I've been invited by the government and by the ministry and by university because we have a big collaboration with Thailand. Here we had a situation where in the parliamentary committee which discussed about that, every member had contact from Canadian cannabis industry before the deliberations. We had basically a election where in a country where 0.2 had used cannabis, and cannabis in this case was medical marijuana, illegal cannabis of different shapes and forms, and traditional medicine of 0.2%. That means almost nobody in Thailand used cannabis in any which way, shape, or form. But there were newspaper reports. Again, a child. We have done some studies with cannabis industry. A lot of those newspaper reports are sponsored originally, i.e. the people who make the reports get money for doing those reports. We had a public campaign, 200 68-kilometer walks for patients, including Cancer Care Thailand was marching for medical cannabis. They were actually marching for recreational cannabis, they didn't know. But I don't know why. And we had this wonderful party who said a medical marijuana policy will be allowed. This party now has the health minister, so it's not a small party which has no impact. This is now the health minister. He said every citizen can grow 6 cannabis plants, which will give every Thai household at least $12,000 of revenue in a country with a GDP of 6,500 at the time when he made this announcement. So basically he promised them to, if they have their normal revenue, triple their average revenue. Of course, this is nonsense. Cannabis industry will never accept homegrown cannabis because they need strictly controlled. So this is just some pictures. This is the slogan of the Thai Cancer Society in the walk, just that you see that I have evidence for what I say. This is an advertising board. I let you read it yourself. I like Thai people now can freely, Thai people should be able to freely grow cannabis. It is freedom associated. And then grow cannabis and you can sell it at $2,000 US a kilo. Yes, that's true for strictly controlled cannabis under controlled conditions. The cannabis industry has not even accepted the traditional Thai marijuana from traditional medicine because they say it's contaminated. They say, well, we'll never buy that or sell it. So there was no economic benefit to date. And there will be no economic benefit. So what are the conclusions? The devils are in the details. Basically, we have a combined pressure of industry and in part sponsored. We did some studies. I can assure you that for some countries we can say in large part sponsored. I don't know how many of those activities are spontaneous NGOs, how many are actually sponsored by industry. I can tell you that the society who is doing most of the stuff in Germany, we went there, we looked into their books, more than 90% was sponsored by industry. It was not real NGOs, it was industry sponsoring about that. And basically, there is this movement of medical marijuana as a hopelessness of governments on the WHO in face of all those media reports. What should we do? What should we do? And WHO usually makes committees, so we're talking about years to come. And we should actually now make a clear assessment. A, do you want medical marijuana? That means, are there any conditions where the plant and the raisin, i.e. the things which you can smoke, is actually more advantageous than a pill or a tincture of cannabis, where we can control the THC? These are the clinical trials we need. If there is evidence, yes, we should allow medical marijuana, but under strict conditions and not as a general for everything. So, second, what are the risk to benefit assessments from a societal perspective, before and after? There are models in every country. Let the models do their job. We know we have evidence. Will the companies pay for the additional costs in healthcare system? We have had a hard time, and we have never succeeded, of the alcohol industry to actually pay for all of the damage alcohol has been doing to our society. Not even half. And their taxes are not covering that. How do we do the taxation for cannabis industry? What happens to drivers? What happens to driver's license? Highly contentious, there are lawsuits in at least 5 countries, human rights lawsuits. We are sick, we're getting medical cannabis. Why aren't we allowed to drive? Yeah, these are ethical questions. Courts will have to decide, but once you start this program, you have to know that this is going to come. We are living in societies, well, Singapore has a lower density than a lot of other countries, but still a lot of people, a high percentage of the population is thriving. Would cannabis users be allowed to? Yes or no? Who will provide the cannabis? The industry, government? Who will control? Who will pay for that? If we have, like now, in my part of the town, which is obviously close to university, meaning lots of students, within 200 meters, I have 15 little cannabis dispensaries. They all get their stuff from different little parts. Who is controlling them? Who is controlling the THC? Who is controlling the labels? It's pretty easy to control alcohol because you just go to the producer and make a random control. I can give you a design how to do quality control. Doesn't cost a lot. But if you have so many little shops, you cannot control because you have to know a lot of things. You have to chemically analyze, etc. So, conclusions. The budget, the impact of medical cannabis has to be considered. Public health has to have a word. We have to consider a lot of things. And the budget considerations should actually be taken serious. Thanks a lot.
Thank you, Prof. Rehm, for the very insightful presentation. Next up is the panel discussion and question and answer session. May I invite Prof. Rehm on stage again to sit with our other panelists, Mr. Sen Chen Hong, Director of the Communications Division at the Central Narcotics Bureau and Secretary of the National Council Against Drugs Abuse, Prof. Wang, Visiting Professor at the Swee Hock School of Public Health and Professor at the Department of Community Health Sciences, UCLA Fielding School of Public Health. And this session's moderator, Prof. Ying, Dean of the Swee Hock School of Public Health.
Right, so that was a very spirited presentation. Thank you, Professor Rehm. So I think now I know that in Canada, either there are people with very little back pain or you have a country with lots of people with back pain. And I know what to say when I go to Universal Health Clinic at the center and I will say I have back pain. Can I get a prescription for medical marijuana? I think it's very useful to start off with this phrase that health is politics. And I think many of you would have seen from the example, be it in Canada, be it in Thailand, that the basis for pushing through some of these health policies have been very much centered around a political movement or a political ideology. Now, when we start to look at some of the strategies or even the ways that the industry, the cannabis industry, is using, they are somewhat very similar to what we have seen before in tobacco or even alcohol, or some may even say the excessive sugar industry as well. And I think this is where we have to be very careful in terms of the views that we would have towards a substance where if the current evidence is lacking on the positive effect, what should a country do? What should a responsible government do? And I think it's very useful to frame this as if we now know, now that we know about the health impact of tobacco use or smoking, if you were the health minister in your respective countries many years back, and you have this new substance that's coming to you for approval, would you have allowed tobacco use in your country, given what we know now about tobacco? So, right now, I started off mentioning that medical marijuana is legalized in many countries, and Professor Rehm also showed the map, and he highlighted that the map is constantly evolving, with unfortunately more blues and more green colors coming in to shade more of these countries. I could name a few. That medical marijuana is legalized in countries like Australia, Canada, Finland, Germany, New Zealand, Thailand, UK. Many of these countries have very good public health system that is governing access and use of many addictive substances, including alcohol, including other forms of opioid drugs. Recreational marijuana is legalized in Canada, Netherlands, Uruguay, and some of the states in America, including where Professor Wang is from, in California. So is medical marijuana seen as a backdoor, that there is eventually this gradual slide, that when a country allows medical marijuana, it is inadvertently allowing recreational marijuana to come in 5 years, 10 years down the road? So that's something that we would like to focus on today. Some of the questions would really also be centered around, is legalizing marijuana, medical marijuana, ultimately a social experiment, which is driven in part by politics, driven in part by very impassioned individuals who swears by the beneficial effects of the use of marijuana, whether it's for themselves or for their children suffering from seizures, epilepsy. But the ultimate fallout and the collateral damage will be an entire generation of youths that have been brought up with exposure to this substance. And I'd like to highlight the context of what has been shown in Canada, that about 40% of the population have been exposed at some point in their life to marijuana. Is it a gateway as well to other drugs or addictive substances, including tobacco? What is the impact when marijuana is now mixed with alcohol? So our speaker showed some statistics around road traffic accidents, around lung cancer, but what about the impact when an individual mixes marijuana use together with alcohol? It is a scenario that is entirely plausible. It is not something that it's rare. I would imagine in many of these parties where marijuana is freely available, alcohol would be similarly available. So some of these questions would be very relevant for us to consider and for me to pose to our expert panel. But while we are thinking about some of these questions, I would strongly encourage you, members of the audience, we have mics set up on all 3 sides. Please feel free to approach the mics later on with your questions around marijuana, medical marijuana, or even recreational marijuana. So with that, I would perhaps like to first start off by inviting Mr. Seng. Mr. Seng Cheng Hong, it's from the Central Narcotics Bureau in Singapore, and perhaps I could invite Mr. Seng to start off by giving us a quick overview of Singapore's current stance around any marijuana use. Mr. Seng, please.
Thank you, Prof. Thank you, Dean. I will just, as the Dean mentioned, that I just give you an overview of basically the drug situation in Singapore. Really, Singapore adopt a zero tolerance position, so regardless what drugs it is, whether it's your heroin, your ice, your cannabis, as long as it is a controlled drug that's listed, we adopt a zero tolerance position. And to share, last year, we arrested about 3,400 drug abusers. This number, if you look at the international or even the regional situation, you will appreciate that to some degree, Singapore is able to contain the drug problem, because if you are looking at the regional situation, in Thailand and Malaysia, you are looking at millions of drug abusers, and in Singapore, very nearby, we have on the yearly basis about 3,000 abusers arrested. Now, among these 3,000 abusers arrested, 40% of them are below 30 years old. And about 15% of these drug abusers are on cannabis and synthetic cannabis. It is not a big number, but increasingly we are seeing a trend of especially young people maybe being influenced by social media, being influenced by what is happening in other countries. They are slowly becoming more liberal when it comes to cannabis. And this is actually our concern going forward. And increasingly we are very focused on how to counter this very pro-cannabis narratives out there. And maybe one thing that I picked up from Prof's sharing is that he emphasized that we should adopt an evidence-based approach when it comes to medical marijuana. And I want to share with you that while we ban cannabis, but when it comes to medical marijuana, we are actually aligned in the sense that we adopt an evidence-based approach. So when you talk about medical marijuana, really we are looking at CBD medication. And there are processes really put in place for individual to apply for such medication. But of course, then you have to go through Health Sciences Authority for them to evaluate whether the medication has proper medical efficacy. And then if it passed through HSA, then CMB and the Ministry of Home Affairs will then review this application for the medication. So we did approve some medication in the past, and this is really based on the evidence-based approach, and I think that works well for us. And I'm just very concerned with what Prof shared, that if we loosen and open up, then basically it will be a floodgate that we will not be able to close anymore. Yeah. So with that, yeah, thank you.
Thank you, Mr. Sun. And secondly, I would also like to invite Professor May Wang, because she's from UCLA, and in California, they have had a very liberal approach towards marijuana, all forms of marijuana. And perhaps, May, you could share with us some of your experience in this area.
Thank you so much, Prof. So, yeah, I've been visiting here for a couple of months, and as some of you may know, cannabis was legalized in California for recreational use in 2016. And I want to say, actually, thank you to Prof. Rehm for a really thoughtful and insightful session, sharing of Canada's experience. I think that one of the takeaway messages I got was really the need to kind of look at the costs and benefits from a societal perspective, because I think that has kind of put us all, I think, all of our heads turned around. And if I may, I'm going to quickly share some slides on the situation in California. I'm not going to go into any detail because you'll see, I think there are a lot of similarities in terms of what has happened in California. So just very quickly, I'm not going to go into any details, but just to kind of give you a sense of this history of cannabis, right? So in the US, it's been around since the early 1900s, maybe even before. And then we had this prohibition period in the 1920s and 30s where even alcohol was prohibited, etc. And then came the hippie culture, the 50s and 60s, where people were experimenting. And then in the 60s and 70s, you know, what they found was almost 80% of cannabis use in the nation was coming from California, which is a very kind of a liberal state in the country. And then in 1975, the Moscone Act kind of made cannabis, it kind of pushed its legalization, partly because you know, there was AIDS, and there was this whole argument that even, you know, that cannabis was helping AIDS patients. So this idea of medical marijuana being a backdoor to legalize use of marijuana, I think is one that is very worthwhile thinking about. So coming from, in kind of moving along from there, when medical marijuana finally got legalized in 1996, this was this Compassionate Use Act of 1996, or Proposition 215 in California. The wording was very, very vague. And just like in Canada, you know, it was kind of the devil's in the details. And basically anyone could get a recommendation from a physician for marijuana use if they had any kind of medical ailment. So the physician just needed to recommend it. But this partly was to kind of circumvent the national, you know, federally. So the United States, just to back up a little bit, we have laws at the national level, at the state level, and at the local level, just to complicate things. So at the national level, it is still not legal. So this was kind of a way to try to circumvent that, and then that resulted in a whole bunch of lawsuits that was coming from the federal government to the state, And then there came this Rohrabacher-Farr Amendment that prohibited the Federal Justice Department, that's from the national level, from spending funds to interfere with the implementation of state marijuana laws in California. So you can just imagine the amount of, I hate to say it, but taxpayers' money that kind of went into all of this. And so a lot of this effort was really pushed, I think, by lobbyists, by industry, et cetera, and then, kind of to decriminalize all of this. And so by 2016, talk about a backdoor, it became legalized for recreational use. I don't mind sharing with you that I voted against it, but maybe in all forms of transparency. And just want to show you just quickly in terms of the counties in California. You can see the map here. This is for legalization of medical marijuana. This is for legalization of recreational use. And it's very similar counties to a large extent. Right? These are actually the more liberal ones. San Francisco, LA, the bigger cities, et cetera, where marijuana use for a time, illegal I guess, was kind of widely prevalent. In terms of how medical marijuana is how people get it, it's kind of, as Prof. Rehm was saying, devil's in the details. There were just a lot of issues, and people kind of went around it. So it was kind of almost laughable to a large extent. Basically, physicians would just write these recommendations for any kind of ailment. In fact, Dianne Feinstein said it was a bit of a joke. So now they've kind of legalized it because it became a bit of a joke, and so why not just legalize it, I guess. And this is kind of the situation that we have right now. Anyone aged 21 years or older would be allowed to basically possess marijuana, and of course there are details about how much, etc., and they can smoke and ingest cannabis. We have some, what are the things that you cannot do? You cannot smoke it, cannabis where smoking is prohibited, et cetera, et cetera. You cannot, use it when you're driving a vehicle, et cetera, et cetera. And I think at this point, this is the most recent issue of a journal from the University of California. I'm from UCLA, but we have 10 campuses, and almost all the campuses are now engaged in research on cannabis because I think people realize that how are you actually going to implement this law without adverse effects on society? And so that's actually a really good resource for anyone who's really interested. I thought I'd show you some of the things that are going on right now because everything is kind of in flux. This was, I think, October, just a couple of days ago. There was an article in the LA Times about the first cannabis restaurant, which is about 5 miles from where I live. I have been away, so I will visit it when I go back and see what this is really like. I was reading about it, and so there's cannabis in food, there's cannabis in there's a room where people can smoke, if I understood this correctly. And interestingly, there'll be separate bills. You can't pay for your cannabis products as you can for food because there are all kinds of regulations. So it'd be interesting to see how this kind of plays out. And this is kind of a high-end restaurant. They're trying to make it kind of high-end. And I guess I might be a little bit biased, but there are issues around the cannabis farms now that are exploding in Santa Barbara County. People are complaining about the smell, residents of the neighborhoods. So we'll see how that's going to play out. I'm sorry. Oops. And then I just wanted to share something that is close to my heart. My research is mostly, frankly, on maternal and child health. And so I've been actually interested in this more from the angle of how it affects teenage development, child development. As you can see here, marijuana use has been increasing. And we're about 23% is 2017. I have a feeling it's probably higher now, of 12th graders who've used marijuana in the past month. I have gotten relatively good at figuring out if some of my students have been smoking because of bloodshot eyes, etc., because I can't be sure. Maybe, they didn't get enough sleep, but just sometimes I always wonder when students talk to me and they're very articulate and suddenly they're not. And I kind of wonder, and then through the back door, I sometimes find out that yes, they smoke marijuana quite a bit. So these are the numbers in terms of marijuana use among teenagers in the U.S. And it is, to me, a big concern. There's some research showing that marijuana use early on in life, while the brain is still developing, might permanently damage the hippocampus, which affects cognitive development, and also the amygdala, which affects the emotions and empathy, etc. So we talk about the impact on society. I don't know how we're going to measure that, but I'm going to guess that there's going to be long-term effects. So I think with that, I'll end. I'm happy to answer any questions.
Thank you very much, May. Sure. And before I open the question to the audience, I would wonder whether, Jürgen, you have any response to what May has shared in terms of the impact on the adolescents, that it's beyond what can be measured by road traffic accidents, by lung cancer, because some of this impact would really be perhaps on the IQ, on the attention span, social behavior. Is Canada experiencing any of this?
Well, the only way we can measure long-term effects in Canada is to wait, because it was legalized last year. Sorry, long-term effects are not possible, or to model. And there is right now in this university, not far away, a workshop on burden of disease. And in the burden of disease model, IQ is one of the determinants. And you can actually measure that. And you can model what you would expect to do. One of the most contentious issues in the legalization, in the debates in Parliament, was whether the legal cannabis should be allowed at age 21, or even beyond that, or at age 18 or 19, that 18 was the lowest. And it is very clear that both alcohol and cannabis have effects on the adolescent brain. It is very clear that overall, if you rationally would like to make those substances legal, you should come up with a minimum age of 21 or above. And that is what usually does not happen, and it has purely biological reasons. But the arguments against it is purely social. We allow the army to come, that is in every parliament I've been so far, that was a major argument. We allow people to go to our army, defend our country, die for our country at age 18, but they're not allowed to take cannabis. Sorry, I didn't get the argument fully. But the truth is that once we model with the global burden of disease these kind of effects, they would probably not go into the mortality, they would go into the DALYs, into the overall burden of disease as measured in years of life which are used to less than perfect health. And yes, we should absolutely, when we legalize a substance, do those calculations beforehand. Second point, which, and I will be very short now to allow you also to speak, I'm sorry. Second point I would like to make is, do not underestimate what happens if a medical marijuana law is introduced which is de facto not a medical law. There's no doubt that our societies should use the best medications. And if this happens to be cannabis-based medications, yes. But then it is a medical model. It is a controlled substance still, so it should be under certain provisions in certain pharmacies only, etc. But to do a medical law, a medical marijuana law, where we allow joints for all sorts of ailments as defined by arbitrary individuals, and sorry, MDs like anybody else can be bought. And cannabis industry has done a good job in California and Canada, wherever. That is not a medical law, that is just legalization of recreational by the back doors. Why would a disease condition be 80% in under 25-year-olds? To my knowledge, our under 25-year-olds are not that sick. And if you want to do a disease condition, please do it by all means, and I'm for it. I would always vote for legal cannabis products as medical products. No doubt about that. But do it under a medical umbrella, under the evidence which we need for any other medications. That's it.
And I think that it's a stance that's very much aligned with what Mr. Sun has mentioned earlier on. At this point, I would like to open this up to the audience. Any questions from any members of the audience? We have 3 mics, or if you're shy to stand up and approach the mic, you could just wave your hands vigorously and we will try and pass the mic over to you. Well, we have a very shy audience. Oh, yes.
Yeah. So I think first I'd like to thank Prof. Jürgen for a very interesting lecture where I think he illustrates the importance of knowing the context and also knowing of path dependency. So I think we hear a lot of the news in terms of the headlines. So it's worthwhile understanding what's going on behind the news, to say what are the political pressures, what are the societal pressures that led to legalization in Canada and then subsequently in Thailand as well. So I think so the other concept, of course, is path dependency, which is to say that I think the best way forward depends on where you are now. If you're in a situation where use is very low, and where support is very low, then there's a different path forward from a situation where I think where we've been turning a blind eye towards illegal use, for example. Right. But I think the main key thing I pick up from this basically is the distinction between medical marijuana and I think the pharmaceutical use of cannabis-derived products. I think, for lack of a better term, probably we can use the term pharmaceutical cannabis. Right? So I think the confusion is illustrated because Mr. Chern himself, I think, used the term medical marijuana, right, when he was depicting the situation of pharmaceutical cannabis. I think therein lies the confusion. I think when one reads the headlines, when one reads the thing, to say that, the confusion to say that actually medical marijuana, the plant and the resin, basically, that there's some implication that it has proven sort of pharmaceutical effects, when actually sometimes the actual data is what is showing the efficacy of pharmaceutical products, right, for treatment of epilepsy. So I think my question to Prof. Jürgen was whether there's any emerging data, right, to show that the plant and the resin is superior, right, or at least even equivalent, right, to current preparations of pharmaceutical cannabis already on the market.
There are currently more than 1,000 registered, randomized, controlled trials for different sorts of cannabis products, including most of them, of course, pharmaceutical products. There is a number of articles in the literature which is speaking about a so-called environment effect, which means that medical marijuana, i.e. the plant and resin as smoked, is having better effects than the pharmaceutical cannabis projects. While there's anecdotal data, there are no randomized trials. Of course, it can't be blind. I mean, you know if you smoke or if you get a tincture, but there's no randomized trials. We will, in about 5 to 10 years, we will know so much more about those, but to date, and I've done the review on this question for the UN. There's a public hearing, there's a meeting of experts, and they invite people like myself to work on certain questions. Today, we have no solid evidence of advantages of medical marijuana versus cannabis pharmaceutical projects. The meta-analysis, which show a slight advantage, still have overlapping confidence intervals, and they are not based on the same populations, so there's additional variation. So the cautious answer at this point is we have to wait for the trials to give us solid answers. Right now, there's no evidence that we should use medical marijuana rather than pharmaceutical cannabis.
Thank you. Any additional questions?
Sorry. Maybe I just want to clarify, because just I mentioned about in Singapore we adopt an evidence-based approach. It's really for your pharmaceutical grade. Example, Epidiolex, that's one of the pharmaceutical grade cannabis. Just to us, I think similar to what Prof mentioned, I think when it comes to medication that need to be administered by smoking, besides cannabis, raw cannabis, I think the other one that I can think of is really opium. So I don't think that's a way for proper administration of medication. So just to clarify that point.
Actually, Mr. Sen, while you have the mic, could I follow up on this with a question around medical tourism? So, because Singapore, we do have very strict laws. If I intend to go to a country and then do naughty things, take drugs, come back, if it's tested, I can be prosecuted. But what happens in the situation of a medical tourist? If I, for some reason, need to seek treatment in a country like Thailand, where medical marijuana is available, and I was given a product containing marijuana. I come back and I get tested positive for it. What would be the implications? Because it is not a specific attempt by someone to take this product.
Sure, thank you for the question. Firstly, to clarify, for Singapore, or rather for Singaporeans or PR, if you are to consume controlled drugs overseas, and you have to come back to Singapore, it's still an offense. So don't even think of going overseas to try.
Public announcement.
So that is an important point I want to put across, because in the past, people do cross over to Batam, to Malaysia, they take drugs and they come back, and so that's why you put in this new law to address that gap. But specific to this question, I think medical cannabis, it's something very new. But of course, I mean, if you are traveling overseas to seek proper treatment and there are proper documentation to show that you are there for medical purposes and the medication is prescribed to you for the medical purposes, if you are to come back to Singapore and it is detected, of course, you will take a very calibrated approach. Investigation will definitely be conducted to establish whether your medication is properly prescribed and all that. Then we are not charged in court, basically. But it will be a very calibrated approach. But of course, there will be many cases where people may go overseas to smoke cannabis, and then they will find other excuses. And these are things we need to investigate and verify. And if found out that you are really out there taking drugs for recreational purposes, then it's a different approach I will take. Yeah. Thank you.
And I think this calibrated approach is still very similar to if I bring certain controlled drugs for medical reasons overseas, often you may need to have a doctor's letter to say that you are allowed to carry this types of substances. So, come on, it's quite rare that you have someone from the legal front and two experts on this area of oh yes, we have two questions. Perhaps we can take both questions at the same time. Why don't you go ahead first, and then we will, yeah.
Hello. Hello. My name's Sam. I'm a PhD student at the school, and thanks again for hosting this discussion, Prof. Teo, Prof. Rehm, and our panelists. And I'd first like to just share a short perspective and then also ask a question at the end. So, actually, I'm from California, and I went to high school during the 2000s, so it was after the Medical Marijuana Act was passed. And during my experience there, I can tell you it was actually very easy as a high school student even to access marijuana. For example, everyone knew someone who sold it on the side, not even at the pharmacy, but someone who perhaps went to the pharmacy or got it by other unscrupulous means and would distribute it to their younger brother, who would then pass it out to their fellow students. And my question, I guess, is because we discussed earlier the concerns about sort of a backdoor approach with these medical policies. Should we also be concerned, I guess, in areas where there is already a high sort of proliferation of marijuana usage, and also places where the laws aren't really enforced very well? Should we be concerned that these policies actually just become nothing more but lip service and not just, backdoor policies for access?
Great. Thank you, Sam. I would like to direct that question both to Prof. Jürgen and also to May, but I would also like to take the second question. But before I take the second question, I would like to ask Sam, have you tried? Be honest.
Honestly, no.
Oh, okay, great. Yes. We did put him on the spot. It would be difficult for him to say yes, and then we have Mr. Sergey.
Thank you. I'm Dr. Joseph. I'm from the Center of Biomedical Ethics and also from the Hospital Ethics Committee and the National Medical Ethics Committee. We had mentioned about medical use. A trend that I see happening is physicians putting up requests for the use of, for example, a cannabinoid derivative, citing various references, and unfortunately, these come to an ethics committee. An ethics committee is not made up of scientists. They're just made up of some doctors, legal people, lay people. And you find that you are in a very precarious situation. An umbrella of urgency, fancy words like compassion, innovation are used, and you're almost sort of forced to agree or to say that the patient is informed or the family is informed. This, I think, is very dangerous, because when the scientific committee knows today that there is no strong evidence, is it not better that, say, for example, in Singapore, that we bring together the professionals who know most about this, for them to study and make a categorical statement whether it is indicated or not, instead of another type of backdoor approvals? It does appear, from what I've heard from your very eloquent speech, that two groups of people who usually are charged with looking after the nation, the legal profession and the medical profession, have sold themselves to the industrial giants.
Thank you. So we have two questions, one from Sam on in the absence of enforcement, do some of these policies become really just rather lip service in nature? And Prof. Jürgen, what is the situation in Canada before recreational marijuana was allowed? You gave the example of going to the back room, call someone to say that you have chronic back pain, you get a fax that says you can get this. What is the enforcement at the time against practices such as this?
That is one of the key questions which I believe every country and every jurisdiction has to be aware of when thinking about cannabis. What is the current situation? Unfortunately, Canada, for whatever historical reasons, had been the country who twice in 10 years with the UN ODC statistics was the country where most cannabis had been consumed in the last year, according to surveys. Obviously, it was illegal, so those numbers have a wide confidence interval, but still, it doesn't matter if it was the top or the second or the fourth. These would all be in the same confidence interval. So we were faced with a situation that even when cannabis was illegal, this illegality was never enforced, which means that there were a lot of people, on average per year, way over 10% in the adults, not the high school students. There, more than 50% had smoked cannabis. And that created a myth of there are no consequences. Obviously, when we speak about consequences like traffic, this was not known that you had a traffic accident. You're automatically tested for alcohol. You were not tested for cannabis. So we had no clue how many of the traffic accidents were actually due to cannabis use. And the second one is the usual lung cancer. As we all know, lung cancer is most prevalent age 60 and above. The average age of a smoking-related death in Canada is 71. So if you're a high school student, you will not die of lung cancer, neither if you smoke cigarettes, nor if you smoke marijuana. And if you may know by yourself that your marijuana may have had an impact on a traffic accident you had, but you will never tell anybody because it would be bad for you. You would have severe consequences. And we did a survey amongst University of Toronto students. That's a top 25 university worldwide. Of those who smoked cannabis, 80% of the students who smoked cannabis indicate that they're better drivers under the influence of cannabis. That's exactly what their grandfathers said in Germany in the 1950s, where Germans, I'm sorry, I'm German by origin, German adult male claimed that they're better drivers under alcohol at the time. Nobody would believe them now if they say that in a party, and they will never say that. But the problem is that even if you use cannabis at a certain time, you do not experience the consequences directly. Some of the consequences are long-term. You don't experience if it changes something in your brain. If your IQ is dropping by 4 or 5, you do not notice. Sorry. And that's part of the problem. We had widespread cannabis use in Canada. We had a lot of people, a lot of testimonies, nothing happened. No, because immediately not a lot of things happen. Same with alcohol. Most people do not experience alcohol-related problems. And if you get breast cancer, for example, where about 10% are due to alcohol in our country, they would not know. They don't have the link. And those are the kinds of things which we as experts have to say. About the ethics, overall, there's no problem, in my view, about properly reasoned uses of cannabis in experimental randomized controlled trial. And the properly reason is something which cannot be described by compassion, by urgency, or by other reasons which have nothing to do with the subject. And I'm sorry, I think it's up to the ethics committee and not for the state to forbid RCTs with cannabis. It is the ethics committee, and they have to argue if there is enough reason to conduct this experiment, this trial, and they have to weigh individual for each trial the benefits and the harm which could potentially result to the individual who's participating in the trial. I don't think there's any way around it but to make this ethics evaluation, and I do not believe there is a role for the state in prohibiting certain substances in total for trials. This will get us into the situation we are currently in, that we do not have enough knowledge about most of the conditions for cannabis because it was impossible to do those trials beforehand. I would rather be here and say, oh, we have 2 conditions for cannabis, instead of, no, we have clear trials, at least 10 trials for about 50 outcomes, and for about those 50 outcomes, for 4, it is a clear evidence that it is positive, and for 46, there's no clear outcome, and so it should only be there for those 4. Sorry, I am a scientist, and I try to do it on evidence, and we cannot get the evidence if we forbid certain substances to be explored.
On this point, I actually wanted to highlight that you use the word cannabis, and I want to draw the distinction between cannabis at pharmaceutical grade as well as medical marijuana, which is just the leaf and the... So, May, very quickly, I thought I would ask you to touch on what Sam has asked regarding what is the situation in terms of enforcement in the state of California before recreational marijuana became legal.
Well, thank you. Thank you for the question, Sam. Which high school did you go to? You don't have to answer. It's okay. So I guess I think the question, maybe what you're trying to ask too, is, you know, we're paying lip service to this. Anyway, why not legalize it? And I think that has been the argument that has been made, and the other argument is that let's control it better. If we, you know, legalize it, then we can control it better. We know what's going on, etc. And what's been happening in California right now is that the illegal market for recreational marijuana is now 3 times the size of the legal market, and that's actually pretty alarming. I'm sure you've all been reading about the vaping incidents in the US. It's become a big public health issue. A lot of young people are getting really sick. They're not sure if marijuana is implicated in vaping or not. But there's just all kinds of consequences right now that are happening, partly because I think we conflated the issue that now if we can't regulate it well and paying lip service to it, why not legalize it? And I think there are 2 issues there. You know, if we can't regulate it well and we don't know what, let's figure out how to do that better. Let's not just legalize it and then we'll try to figure it out. I think that's the argument that has been going on. And frankly, my head has been turned around too. My colleagues' heads too. We discuss this a lot. Of course, many of my colleagues, having grown up in the US, smoke marijuana, and they even support it. You know, and at the same time, the idea is what harm is there, because we've done it, and it was fine. It was just a teenage thing growing up. But I think that there is evidence suggesting otherwise, and then there are also consequences that I don't think we really understand. I'll give you an example. I actually was personally very concerned about a young man who was actually incredibly bright, smoking marijuana. And so I did a bit more research online to just see what young people were thinking and saying. And I found these blogs. I will say I haven't done any research on this formally, but it was alarming to see blogs where young people, young parents, are actually recommending marijuana use to help them become better parents, because the reasoning is that it de-stresses them. And so after a hard day's work, when you're less stressed, you become a better parent. I mean, there's something wrong with that thinking, I think. The logic there is just doesn't quite get there. And so I think we really do owe society, and we owe our young people, a real effort to try to kind of address this issue and not allow the politics to kind of come in play, which unfortunately often does.
Right. So I've been told that I have not much time left and I have to round up. So I thought what I would do is very quickly just highlight that the world is facing the same threat that marijuana use would now be denormalized in the society, very much like how alcohol, tobacco have been denormalized, that the society has been deemed that it is acceptable to use it. It is perhaps even fashionable to some extent for young adults to indulge in it. And I think we have to ask, for a society like Singapore, where we have very low prevalence, extremely low, and I will look to Mr. Sung. Our speaker cited the figure of 0.2% in Thailand. I suspect, I have no evidence, but I suspect in Singapore it will be a figure that is even lower than 0.2%. That if we have such low prevalence, it's medical marijuana a substance that we would want the image to be denormalized. And there is a clear distinction from pharmaceutical grade cannabis that I think our speaker, Mr. Sung, and also Mr. Derek Heng from the Ministry of Health have specifically highlighted that if there is strong evidence for some of this cannabis-based pharmaceutical product for certain medical condition, those will be approved by our Health Sciences Authority with appropriate consideration. But what we are guarding against is just this rather relaxed definition of medical marijuana, or even the perception that individuals can start to grow plants and to use those for their own treatment. Now, traditionally, we would ask everyone to end off with an advice for the policymakers or for us as individuals in the society around the issue, and I would like to do the same as well. Perhaps this time around I could start from May before Mr. Sung. Very quick 30-second sound bite in terms of what you would like our audience to leave with on this topic of medical marijuana.
Oh, that's a tall order. I think I would like you to really think about the consequences, the potential consequences of making marijuana, medical marijuana, legal, having seen what's happened in Canada and elsewhere.
Thank you.
Yeah, so I just want to share that what we have put in place in Singapore works to a large extent because we are able to contain the drug problem in Singapore. So to echo what Minister of Home Affairs said during a UN session back in 2016, he basically told the UN members that unless you can produce or show me a model that works better than what we have in Singapore, otherwise don't expect us to change because what we have here works. So with that, I will end up. Yeah.
Thank you.
No reason to legalize marijuana in Singapore. No reasons and no good evidence to adopt a model with a very liberal medical marijuana policy. Continue to look at the evidence and allow all medications which fulfill the usual criteria from your, I think it's HSA, you said?
Yeah.
From your HSA, and this can be pharmaceutical cannabis products, both containing CBD or THC, if they fulfill those criteria. Otherwise, I see no reason to change policies.
With that, I thank all of you as well as the panel for having a very productive discussion around the topic of medical marijuana. Thank you.
Thank you, Prof. Rehm, Prof. Teo, Mr. Seng, and Prof. Wang for the very enjoyable and insightful discussion. Before we wrap up the session, I would like to invite Dean Prof. Teo to present a token of appreciation to our panelists. First, to Mr. Seng Chen Hong. Prof. May Wang. And last but not least, we'd like to present this very special token of appreciation to Prof. Rehm. We understand that Prof. Rehm loves his tea, and we hope that he will enjoy his next tea time with this special teapot set and remember this special visit with us. It is customized with illustrations of the early and modern day Singapore.
Thanks so much. I'm teaching.
We've come to the end of this session, and thank you everyone for joining us here today. We hope you enjoyed yourselves. Thank you. Please enjoy the rest of the day.